very warm welcome to Sir Bruce Keogh, who joins us today. Many of you will know that this is right in the middle of our perfect week, and Bruce is present today, completes that perfect weekend for us. Today is another event in a series of events that we're trying to host at the Acute Trust to bring an external perspective to the health economy, and it follows on from the lecture by Professor Tim Evans on the Future Hospital Commission that some of you will have attended a few months ago. I was in London recently and heard Sir Bruce speak on a variety of subjects around intervention on safety matters, 7-day services, emergency departments, and I was struck with his passion and focus that he has on the patient, a passion and focus that certainly we share. And so he kindly accepted the invitation to come today and share some of his thoughts with you around ambition and opportunity in the NHS. Before I hand over to Bruce, by way of introduction, Bruce is NHS England's Medical Director. During the transition to the new NHS structures, he's continued his role as Medical Director for the National Health Service in England, responsible for clinical quality, policy, strategy and postgraduate education. Formerly, Bruce had a distinguished career in surgery. He was the President of the Society of Cardiothoracic Surgery in Great Britain and Ireland, Secretary General of the European Association for Cardiothoracic Surgery, International Director of the US Society of Thoracic Surgeons, and President of the Cardiothoracic Section of the Royal Society of Medicine. So he knows his stuff. He served as Commissioner on the Commission for Health Improvements and the Healthcare Commission, and was knighted for his services to healthcare in 2003. Prior to becoming that, though, he was a practicing cardiac surgeon. Bruce's team was responsible for implementing the majority of the recommendations from Lord Darcy's review of the NHS, High Quality Care for All, published in 2008. And that review has been credited for refocusing the NHS on quality of care. Bruce's team also developed the quality framework for the NHS. More recently, in 2013, he published 3 significant reports. One on how to improve safety in the cosmetic intervention industry, a second, widely known as the Keogh Review, on the 14 acute trusts with the highest mortality rate in England, and the third, presenting a vision for the future of urgent emergency care in England. He's currently leading the forum on how to move the NHS towards greater 7-day services, and those recommendations initially were approved by the NHS England Board last December. During 2013, he was said by the Health Service Journal to be the most influential clinician and the 6th most powerful person in English NHS. And this year, he was included in the Sunday Times list of Britain's 500 most influential people. Pleased to welcome to the Trust at Worcestershire, Sir Bruce Keogh.
Well, thank you very much, Harry, and thank you to everybody for putting time aside on a Friday to come and listen to a few remarks that I'll make. I have a long association going back with Worcester because one of the things that Harry didn't say was I spent about a decade as a cardiac surgeon in QE, and I recognise quite a few faces around the room. I'm slightly worried that they recognise me and know more about me than Harry does, but we could come to an agreement on that. The NHS was said by Nigel Lawson to be one of the closest things that this country has to a national religion. And when you reflect a little bit more on that, I think there's an element of truth in that, because religions have factions, they have schisms, they have liberal wings, they have fundamentalist wings, they have people with different views and people who interpret whatever the writings are in ways that suit their own personal circumstances the best. And having said that, this is still something that we need to be really proud of, because our NHS, despite what you may see from time to time in the media, really touches people's lives at the time that they need help most, at the time that they're feeling most vulnerable. And there are very few other countries that can offer that to such a broad spectrum of the population, free at the point of delivery, without prejudice. And I think that's just something that's really marvelous. When I think back to how we kind of got to this place, it started largely during the last war. and it started during the Blitz, because up to that point, all military people got free medical care. And once the bombing of London started, we started to have civilian casualties. And the issue was how to handle that. So they were offered free health care. And during the war, a number of things became apparent. There was full employment because of all the rebuilding and manufacturing industries. But there was a new social conscience that began to emerge after the war, where people were fearful of the past and wanted a new future. They didn't want to go back to where they had been. And that is encapsulated in a book by Nye Bevan when he set up, in about 1952, entitled In Place of Fear. The NHS, and indeed the welfare state, but in particular the NHS, was built to try and relieve people of the fear of what might happen to them or their families or their children if they needed medical care and couldn't afford it. And it's quite intriguing to think of what the politics was like around about that time. So you'll all know that the NHS started in 1948. But in 1947, it wasn't as though things were easy. There had been the worst floods for 53 years. There had been a harsh winter. A combination of the two of those had delayed the spring sowing. So the crops were late and they weren't very good when they appeared. The price of foodstuffs went up. There was an economic crisis, which meant that the pound fell against the dollar, which pushed food prices up even more. And the meat ration was halved, the bacon ration was halved, bread ration was halved, potatoes were rationed for the first time. So it was worse than it had ever been during the war in terms of the environment in which people were living, although it was peaceful. And yet, the politicians and society were able to deal with massive change. So the hypothesis that I put to you is that in really difficult times, great things can be achieved. And I'll come back to that in a minute. But Nye Bevan then went on to say that the NHS was the most civilized achievement of modern government, and it was something that we could be really proud of, and indeed everybody was proud of it. But here's a second hypothesis, which is perhaps slightly less popular. Like a great building, the NHS started to go into decay. Years of underfunding, years of complacency, while other healthcare systems began to catch up. So I remember in the early kind of 2000s, sitting in an outpatient clinic at the QE, and people, some of them from Worcester, actually, coming into the clinic. And we'd go through a 45-minute consultation, discuss the pros and cons of surgery and alternatives and all that sort of stuff, and then get to the hardcore facts about the risk of death, stroke, and so on and so forth. And then I'd get to the end of the consultation and say, any questions? And the man, because it was usually the man that needed the operation, would say no. And I'd turn to his wife and say, any questions? And she would say, just one. And I'd say, what's that? But I always knew what was coming. She said, when? And I'd say, 18 months to 2 years. And then this look of abject terror would descend across her face. Her eyes would cloud over with tears, and she'd say, but we had to wait a year to see the cardiologist. We had to wait 3 months to see you. We had to wait for the angiogram. When is this nightmare going to stop? And I think at the time, I didn't really get it. I didn't really get how important that was for patients. And it was only later, after we had had a national service framework for coronary heart disease, which was coupled with doubling of funding for the NHS, that I realized that this was a really important part of the treatment for patients, is giving them reassurance that not only will they get good care when they get to the treatment, but they don't have to wait that long, and nothing bad is going to happen in the intervening space of time. Now, the reason we had kind of got, I think, into that bad place was in part complacency, in part underfunding. The NHS had consistently received funding of about 4.6% per year since its inception, but round about 2000 it was doubled, and a number of initiatives were put in place to deal with major problems such as cancer, heart disease, renal disease, mental health, and so forth. And by the time I had finished my clinical practice at the end of 2007, when I was working then at the Heart Hospital, which was part of UCL, people would come into the clinic, a man and his wife, be a different person, I'm glad to say. And we'd have a similar conversation, and the person's wife would say when, and I'd say, well, what about Thursday after next? And again, a kind of look of abject terror would descend on their face, and they'd say, well, we thought waiting lists were long. But actually, and we'd planned to go on holiday. And so now the holiday was up in the air. But at least it meant that we were in a different place. And then as we got to 2008, Ara Darzi, who was a colorectal surgeon at Imperial College, was brought in as a minister in the government with a view to doing a review of the NHS, which he did, and it included consultation with about 60,000 people working in the NHS. I was brought into the Department of Health as medical director at the time. And we learned three things, I think, from Ara's review. One was we needed to put quality at the center of the NHS. It had kind of drifted off. You know, everybody had got really interested in the technocratic aspects of keeping the money under control, keeping waiting lists under control, and many organizations had simply lost the plot. And quality had just drifted off into the periphery, and yet it was at the heart and soul and in the minds of the people that went in every day to deliver services to patients. The second thing we learned was that we needed more clinical leadership in the NHS, that in a sense, clinicians and managers had drifted off into slightly different tribes in many areas. And then the third thing that we learned was we needed to focus more on personalization. Now, personalization means different things to different people. At one end of the spectrum, it means courtesy. It means decency, the sort of stuff you would see in the hotel industry. It means standing up in a clinic, shaking hands with your patients, opening the door for them, that sort of thing, offering people the same sort of courtesies when they come into your clinic that you would offer a stranger coming into your own home. And at the other end of personalization, there's the really hardcore stuff about the pharmacogenetics of healthcare delivery and how you can target people, how you can get the right drugs to people the first time. And there's a big future in that. And then we kind of got to a place where people were signing up to most of this philosophy, and then there was an election. And a new government came in with new ideas, and Lansley came in and he had a number of ideas about the NHS, which resulted in a lot of restructuring. But underneath it, there were three principles with him as well. The first was, he said, we need to make clinical outcomes the currency of the NHS. The second was, we need to improve clinical leadership, and by that he meant getting the clinicians to engage in the totality of the leadership agenda, which involves taking hardcore responsibility for some of the financial decisions that are made. And then finally, that there needed to be more focus on personalization. But in his mind, that was something slightly different. That was more about patients having a greater say in how they're treated, where they're treated, and when they're treated. And all of those are pretty noble things. When I think back to discussions over 20 years in surgical coffee rooms, people saying, well, if only they'd focus on the outcomes, if only they'd leave it to us, it'd all be fine. And so all of a sudden, the bluff had been called. So we had to do something about that. And one of the great things about working in the Department of Health at that time was I was surrounded by a bunch of civil servants, pretty well all of whom were much smarter than I was. And one guy called John Stewart, I said, John, we need to sort out how to make clinical outcomes the currency of the NHS. And he went, yeah, okay. And off he went, and he rang about 48 hours later, and he said, I think I've got it. He said, there are 5 things that any healthcare system in the world should do if they're going to function well. The first is you should stop people dying prematurely. The second is you should look after people well if they have a long-term condition. The third is that you should treat people effectively if they have a short episode of illness from which they can recover, broken leg or cataracts or something like that. He said they should be treated decently. And then the 5th thing is you should treat them safely. And in my mind, what I mean by safety, and you'll see a lot of things written on the back of this agenda that are not genuine, what I mean by safety is that patients accept the risk of their disease, They accept the risk of treatment. What they should never have to accept is that the way that we deliver and design our services will negatively impact on that risk for them. And I find that personally a pretty clear kind of definition of what the safety agenda is about. So we set about then trying to integrate those 5 domains into the way business is done in the NHS. And I won't get into the technocratic stuff of that now, but if anybody wants to talk about it in questions, we can do that. So we were getting into a different place. But meantime, there were bad things going on in the financial markets. The subprime mortgage stuff was beginning to emerge, and difficult decisions had to be made. David Nicholson was then the chief executive of the NHS, and even before the magnitude of the global financial crisis had been realized, he said, we've got to take 40% of management costs out of the NHS, which he then did over the course of the next 18 months or so. I have to say, I, as a clinician on the board, said now's not the time. Actually, you need good management when you're going through massive change. But in any event, we're kind of where we are. Now, when I look at the things that are going to drive healthcare over the next probably decade and a half, I think there are probably 4 things. The first is economics. The second is science and technology. The third is a set of expectations, and the fourth is demographics. And I put them in that order, and people think, why isn't he put demographics first? I put demographics at the bottom because actually if you've got enough money, you can deal with anything. So money becomes the number 1 problem that we have to face in the NHS at the moment. So I'll come back to the global financial crisis. 50% of the world's economies were getting into a debt workout. The amount of money that was available for different healthcare systems began to plummet. So in our healthcare system, for the first 60 odd years, we had an annual increase in the amount of money that was available of about 4.6% per year, which generally kept up with the increase in demand for the services in the NHS. Over the last decade, or the previous decade to then, it had been closer to 10% in order to catch up a bit. But difficult decisions had to be made about how to deal with the imposition of the financial crisis. We had a massive national debt. Every person in this room every year is paying about £1,000 in interest on our national debt. It's massive. And so the government were left with a problem in determining how to deal with the debt problem. And they had 2 options, really. They had one was to increase public expenditure, create jobs, use those to build infrastructure, I don't know, bridges, schools, things like that, and wait for the economy to recover. And that was the basis of the Obama stimulus package. The second alternative was to slash public expenditure, create a vacuum, and allow commerce and industry, entrepreneurs and others to step in to create jobs and to create taxes that would help to build both the economy and the private sector. And I think it's fair to say that, broadly speaking, in the West, most countries, in Western Europe rather, most countries accepted the latter option, to slash public expenditure. So all of a sudden, our NHS went from an expectation of the annual revenues increasing to one where they would remain relatively flat for the foreseeable future. And by flat, I mean not just numerically flat, but we'd get the same amount of money plus inflation plus a tiny bit more. But actually that's not really enough, because healthcare inflation runs higher than general economic inflation. So in real terms, it's a reduction in the amount of money that's available. So we had a problem. And the same has happened in other parts of Western Europe, and it's created really massive problems. The Greek healthcare system has almost collapsed. They're starting to see the emergence of malaria, which had previously disappeared. They're in desperate trouble. Other parts of Europe are re-looking at what the compact is between the citizens and their public healthcare systems. Ireland is slashing the salaries of people who work in the healthcare system. We've got to do something. And so we embarked on some very rudimentary sums, and we worked out that demand was going up 4 to 5% per year. The amount of money was the same, so that over a period of about four to 5 years, a gap of £20 billion would open up. In other words, we would need that money to meet the increased demand. So the question was what to do. So we thought that 40% could come from doing things centrally that were currently done in many different places. So procurement would be an example. Another kind of easy picking, if you like, was a salary freeze, and there were one or two other things. The next 40% would come out of sweating the assets of the NHS, and you've borne the brunt of that. That means greater productivity through the same resource. And then the remaining 20% comes from delivering services in a different way, in a very different way. And that, I think, is where organizations such as this, with good managerial and clinical leadership, can start to address some of those issues. And they're not trivial. So Macmillan did a study in Manchester, and they found that 50% of the cost of treating patients with lung cancer or patients with breast cancer was borne by 10% of the patients. So I said to the chief executive, well, of course, you'd expect that because there'll be some really complicated patients. He said, no. So those weren't the complicated patients. He said those were the simple ones that were just bounced around the system like a pinball. So there is something about what we can do to reorganize services to make them more efficient and equally more patient-friendly. So the next area where I think there's going to be a big impact is in science and technology. Now, science will continue to advance as science does. But I'd invite you just to think for a while on the role of technology. And by that, I mean IT. And there are two things that are going on. On the one hand, we have the internet, we have the World Wide Web, which means that there's a growing population of people who are on Google, who are on other search engines, who live in a world of immediacy, who don't want to be sitting in a waiting room, an interesting term in its own right, who don't want to be sitting in a waiting room looking at Sunday Times magazines that are 3 months out of date, waiting for somebody to call them in. They want immediate answers, and they want them 24/7. They don't want them at the convenience of the people that are providing the service. So we have to kind of tackle that emerging issue. We have to think about what that means for people who seek advice outside of their immediate regions, and in many cases, increasingly outside the United Kingdom. And that's not true, that's not true just for patients, but different organizations in this country are doing now what other industries have done for a long time. And an example would be John Radcliffe Hospital, my old hospital, UCLH, getting their x-rays reported in New Zealand while it's nighttime here and it's daytime there, and then the reports are ready for you the next morning. And that raises a lot of complicated issues. But the other thing that's happening is that we've got mobile technology, which is beginning to emerge in a way that we haven't seen it. When I first started working at the QE, I had this phone. I had a terrible contract with some company who I wouldn't want to mention while I'm being filmed. And it never really worked. There was never a signal when you wanted it. It was crackly, it was big. Now, of course, everybody has some kind of thing like this, which is going to be responsible for the creative destruction of healthcare as we know it. So you pick up your phone and you think, well, that's all very well, it's a phone, yeah. I can do my texts, that's fine. I can look at my emails. It's actually a camera, it's a photo album, it's a video recorder, it's a GPS locator. Then I get a few apps and it can do a whole bunch of things, and then I connect to the wireless and the internet, and it's an encyclopedia, it's all sorts of things. Well, actually now we're getting to a point where you can get a high-fidelity ECG off your mobile phone. You can use the camera to measure the refractive index of your eyes. You can do Fourier transform analysis of the blood flow through your finger and look at your pulse rate. You can get quite accurate measurements with relatively small sensors of your respiratory function, and so on and so forth. Now that is really going to transform the way we deliver healthcare. In the sense that we know that about 25% of people in our hospitals don't need to be there if they could be properly monitored at home or if there were decent social services available. And I put it to you that the application of technology and small sensors which act as digitizers of the human and can transmit that information to some kind of facility in the cloud where there will be analytics which can be granted by permissions from patients. And that will lead to an opportunity for us to treat patients at home with as much effectiveness as we treat patients in hospital in some cases at the moment. So you can imagine a scenario with somebody wearing some sensors who is a frequent flyer in and out of hospital with incipient heart failure. You can picture a scenario where he's being monitored at home and his phone goes and someone says, you know, you're about to go into heart failure. We're sending a nurse around to give you some more diuretics or what have you. It seems pretty far-fetched, but this technology is already here, and these applications are already being used in pockets around the Western world. And one of the things that kind of worries me is the role that fear will play in all of this. So Nye Bevan's book, In Place of Fear, meant that people were worried about what would happen to them. They were worried about the present, and they wanted a new future. Well, one of the issues we have in certain parts of the West is that citizens are pretty comfortable with the healthcare system they have, and they're frightened of the future because the use of technology, reconfigurations, different models of service become a fear rather than an opportunity. Meantime, in the third world, people are fearful of the present. They don't like what they have, so the future becomes an opportunity. And that's why we've seen mobile banking take off in Africa with much greater vigor than it has in Western Europe. And the question is, are we going to be subject to the same kind of inbuilt delay through fear in our healthcare system? The next thing which is going to influence healthcare over the coming decade, and I think you're going to see quite a lot of it over the next 10 months, is a set of expectations, public expectations, professional expectations, and political expectations. But most governments would expect, and people expect, to get a high standard of healthcare wherever they are. They expect that to be value for money, particularly in a tax-funded system, and the governments expect that to work in a way that provides economic growth for the country that they govern. And maybe we could talk about economic growth and the role that the NHS could play in that. And then finally, there's the issue of demographics. So the big challenges, I think, that we face are the economic challenges, which should stimulate change in an environment where people are frightened of change at the moment, which is in remarkable contradistinction to 1947. Now, I think our NHS is uniquely placed, though, to really grasp a number of nettles. So, when you look at the objective evidence about our health service, there are a number of independent observers outside of this country who regard our healthcare system as being really good. And I'm really proud of that, and everybody in this room should be too. The Commonwealth Fund have recently rated us once again as the best healthcare system in the world, the most efficient. But clearly, we're not perfect. But I think we're only a stone's throw away from actually being demonstrably the best healthcare system in the world. And I think that stone's quite heavy, but I think it's throwable. There are a number of things that we're going to have to grapple with, and I think we're uniquely positioned to grapple with. We're the biggest semi-integrated healthcare system in the world. That's the first point. The second point is that we have a fantastic university sector in this country. 4 of the top 6 universities in the world. We have a number of inventions to our name. In this country invented the thermometer, the intraocular lens, the ECG, did the first blood transfusion, learned how to stop the heart electively, invented the MRI scanner, the CT scanner. That's massive. We've produced the IP, if you like, for 14 of the top 75 drugs in the world. We have a massive pharmaceutical export industry, which is, I think, probably our second biggest export. And per capita of population, we have twice as many Nobel Prize winners for medicine and physiology than any other country in the world. So if you start to couple that ambition with the fact that we have a big semi-integrated healthcare system, if we could link those two in some way, we could be absolutely unassailable. And I think that's absolutely achievable. We have some interesting opportunities here. So I've alluded to mobile technology. I think we can probably adopt that quicker than many other healthcare systems. And in a sense, it's going to come whether we try and adopt it or not. It's going to be forced on us. And I was reflecting on that earlier in the week, and I found myself thinking, what is it that big companies do when they're in a tight economic environment? The first thing they do is they take control of their finances. Well, actually, our NHS finances at the moment are in reasonable shape. There's a widespread belief that we need more, but we're in reasonable shape. The second thing they do is they ask their customers what they want. The third thing they do is they innovate, and they do those two with urgency. But I'd invite you to think for a while how good our NHS has been over the last 50 years in asking people what they want and then innovating accordingly. I just think it's a slightly depressing reflection, really. And I was relaying that to Stuart Rose, who had been chief executive of Marks and Spencer. He said, there's one other thing they do, which I hadn't really thought of. And he said, they offer the public something they don't know they want. And it's a bit like Steve Jobs producing the iPad. And you saw the initial reviews of the iPad, great gadget, but not much use. And I thought they do that to get financial and commercial advantage. But actually we could use it in the NHS to show people new ways of delivering clinical services that not only save money but improve quality. And I don't have any answers, but I just raise that as a suggestion. The other area where I think that we could score over many other healthcare systems is we have more data about our healthcare system and about our patients than almost any other healthcare system in the world. We don't have it all linked up. So we have hospital episode statistics so that you know what's going on. We have some of the best electronic records in primary care, but they're not linked up. We have quite a bit of information about what goes on in social care, and again, that's not linked up. And meantime, you've got Tesco's, Sainsbury's, Waitrose, all knowing more about you than you would think. They even have algorithms where they can work out what men buy before they're going to get divorced. An interesting observation which struck me as... I haven't mentioned that to my wife, actually. The next area that I think we have a massive opportunity in is in genomics. Now, I talked about pharmacogenetics right at the beginning. The Prime Minister announced the end of last year that we're going to be the first healthcare system in the world to completely sequence 100,000 genomes. And I could see a lot of people saying, well, yeah, that's all very well, so what? But I'll tell you what the so what is in my mind. If you think about sequencing the human genome, the first human genome took 13 years to sequence, and it cost $2 billion. I've got a team working on how we can develop this now, so they kind of look at what's happening in the rest of the world. We know now that in Beijing, they can do it. We're not quite sure of the price, but somewhere around about $300 or $500, and it takes about an hour. So what that tells you is that in relatively short order, in the same way that the changes in superconducting technology mean that handheld MRI scanners will be here in a decade, that genomic testing has the potential to reach point-of-care testing within our lifetimes and sooner. So we're in the process of trying to work out what this potentially means. And we think that we can do it, and we'll be going out to tender, asking organizations who think that they can contribute to this to put in submissions in the next couple of weeks. At the moment, we know that the treatment of adenocarcinoma of the lung is almost entirely dependent on understanding the genetic mutations which underpin that. When I was a medical student, there were only 4 different types of breast cancer. Now there are more than 40. And the treatments are targeted according to knowledge of the genetic sequence underpinning the malignancy. What we don't know is what other things the human genome can tell us. So in my mind, we kind of get to a place where in sometime in the future, a baby is born. They have a heel prick. At the moment, that heel prick is sent off. They test for phenylketonuria and other things. They do chemical tests. But in my mind, that'll turn into a genetic test. They'll sequence the genome. Then they'll have a word with the parents and say, Johnny is healthy, fit baby, but he has the genes for colon cancer, and he has the genetic predisposition to get early cardiovascular disease. And the parents will then feed Johnny plenty of bran or what have you, and they will look after him in a way that doesn't encourage him to do things that help him generate cardiovascular disease. Because we know that your genetic sequence will determine half of you, and that your phenome, your environment, will determine the other half of how you develop. So the kind of phenomic influences will become strong. And once we get to that kind of place, it's really interesting because you can use the genome for preventive medicine as well as for treatment. You will be able to help people live longer and healthier lives. And the mystery of what you're going to die from will presumably still remain. But it will transform medicine. But more importantly, I'd just like you to think what that kind of knowledge means for people in an insurance-based healthcare system or a healthcare system based on private funding. You remember when you couldn't get insurance unless you told them what your HIV status was. Imagine if your genome shows that you are subject to a number of different diseases. And therefore, I say to you that for those that are saying our NHS has reached its sell-by date, I think we're coming into I was going to use the term buy-by date, but that doesn't quite sound right. But we're coming of age, because the pooling of risk, financially and otherwise, across the whole population, means that we can continue to serve the values of our NHS, which is absolutely equitable and fair access to healthcare services in a way that other healthcare systems will struggle with as this new technology emerges. Thanks very much.